Well, good morning. Of course, it is late evening in Boston, and it is a thrill to present to you the Mayo Clinic experience, building platforms over the last 2 years as we think about how to take the data of the past and leverage it to create the cures of the future. So tonight, or should I say this morning, I'll review with you the plans Mayo Clinic has made for its 2030 Bold Forward strategy and how we have begun to build the software components, the processes to ensure fair and equitable care across the globe. So let's go to the next slide. Mayo Clinic believes the patient always comes first. I am a father, I am a son, I am a husband. I'm almost 60 years old. If I were to ask the question, do I have the digital tools and the data to ensure that I can provide a seamless healthcare experience across the generations I support? I would argue that in 2021, I do not. I would argue that care throughout the world is often fragmented, often challenging to navigate, often complicated. As a physician, I will tell you that very often I am asked to help people navigate to the right care at the right time in the right place that they need. Don't all of us want, as we look at the next several years of building new digital tools and building new processes, care that is proactive, not reactive, care that is continuous and not episodic, care that recognizes, as we heard from the last speaker, phenotype and genotype and telemetry, and integrates that to ensure you are getting an action when you need it. And of course, it should be convenient and accessible anywhere. Singapore is amazing, and I've watched the innovation in Singapore, the can-do attitude of Singapore. I'm absolutely confident that you are on the right path. And Mayo Clinic believes that working together, working in partnership, collaboration, and joint venture, that we can achieve this 2030 vision. And there are a few components to it. So we go to the next slide. I think we all recognize that we need the best scientific data if we are to achieve new cures. So new diagnostics, and new therapeutics, and new techniques. Of course, we will disseminate innovation and ensure that all people, regardless of socioeconomic status or geography, get the cures that are invented. But we recognize as well, we need to do a better job at connecting people. I know Singapore has many efforts to gather data from wearable devices in the home, devices that you carry, ensuring there is this ubiquitous flow of digital information, of novel sources of data. Now, of course, taking into account local regulations and privacy concerns and security concerns, those are foundational. So if we are offering new cures and offering more connections, then we will be able to transform the healthcare system. As I say, we will take the data of the patients of the past and use it to guide the care of the future. We will think about new paradigms for care, new locations of care, new ways in which we can make care more convenient, more home-based or in non-traditional settings. Mayo Clinic's Bold Forward 2030 plan is investing very significantly in all Mayo Clinic sites, but also in our international collaborations to bring this cure, connect, and transform approach to reality. As I say, I will be telling you in some detail as to the Mayo Clinic Platform's approach to especially focusing on transform. Next slide. Mayo Clinic Platform was founded in 2019 with the idea that through joint venture, collaboration, and partnership, through the use of large amounts of population health data and new techniques in the use of digital devices and monitors and sensors, that we are going to be able to bring science from bench to bedside more effectively and improve people's lives. Because really, that's what it's all about. It's about ensuring that we have a healthier world. So let me explain what that means and how we approach it. Next slide. This is going to sound like a very peculiar example. This is a John Deere tractor. I happen to be coming to you this morning, from Unity Farm Sanctuary, the largest animal sanctuary in New England, where I oversee 300 animals in 22 barns and 100 acres when I'm not working on Mayo Clinic Science and Innovation. The tractor that I own is a John Deere 2032R. You may think this is a vehicle. It's actually a data source. You may think a tractor company sells equipment. It's actually a data company. About 5 years ago, John Deere decided to become a platform for precision agriculture. It instrumented every one of its tractors with GPS devices, with sensors that can sense what crop is being harvested, the quality of that crop, how it's being harvested, the speed of the engine, the maintenance cycles of the device. Does this sound like healthcare? John Deere has created the largest precision agriculture database in the world and has created hundreds of partnerships to leverage that precision agricultural data to create new apps, new visualizations, new predictive models, and ensure that farmers are productive. But also, commodities are priced based on forecasts created from the data of all farmers. Yeah, doesn't this sound a bit like population health? So I use this as an example because if we can do this for agriculture and tractors, shouldn't we be able to do it for patients and healthcare globally? So here are our ideas. Next slide. So keep that tractor example in your mind. The first step is gathering data. Now, when we think of data, as we heard from the last speaker, of course, there's electronic health record data, typically structured data like problem lists and medication lists, allergy lists, laboratories, care plans, care teams. There's unstructured data, notes and reports. But there are also data sources like telemetry, the devices that you wear, the devices that you carry, the devices in your home. There's imaging data. There's omics data. There's exposome data, where you live, what you eat, and data from even things that are not yet digital, like the glass slides used for histology or pathology. Now, I recognize Singapore has been very advanced in its use of digital pathology, but much of the world is not. So our first problem is to gather and curate all of those different novel data sources and align them into a longitudinal patient experience. This can be quite difficult. Recognize that certainly across the world, many records are siloed and segmented, so there isn't a longitudinal record of an entire lifetime of patient experience. Mayo Clinic has spun out a company called Lucem Health with the idea that this company will focus on the novel sources of data, the data that is not yet standardized or easily accessible, so that we will increase our existent structured and unstructured electronic health record data stores with all these other novel and emerging types. Again, much of that will be objective, but some of it will even be subjective. As we heard from the last speaker, patient-reported outcomes, certainly very important. Notions of patients subjectively describing pain scores, flexibility, or activities of daily living, all very important. So gathering, very critical thing. Now, if we have all these novel data sources and we curate and assemble them, we then have a basis for doing discovery. I think we all agree that giving clinicians more data is not going to be helpful. They're already overburdened. and asking them to look at 10,000 normal blood pressure measurements is not going to have a positive outcome. So how do we take a very large corpus of multimodal data and do discovery on it in a privacy-protecting and ethical fashion? Starting in January of 2020, Mayo Clinic began to de-identify the structured data that it has stored for decades. De-identification of structured data is not so difficult. In the United States, for example, our HIPAA law says there are 18 different identifiers. Every country has their own privacy laws. And in fact, if it's structured data, you can redact or remove information to comply with those privacy laws. From January to April, we moved the de-identified structured data on 10 million people to a secure container in Google Cloud. Only Mayo has the keys, fully under Mayo control, and Mayo can invite partners in to use that structured de-identified data to create new care plans, new cures, and new algorithms. But very importantly, much of the richness of our data exists in the unstructured notes and reports. For example, if we were to take cancer care, understanding tumor progression and staging, understanding aspects of the genome or biomarkers, very often is put into the unstructured portion of the record. De-identifying data that is unstructured is quite hard. Because you can imagine we could remove the name, the address, the phone number. But what if an unstructured record says, this Massachusetts senator has a disease? Well, of course, in Massachusetts, where I am sitting, there are only 2 senators. So I think we could agree that is not de-identified data. And so hence one has to look at the unstructured data and using natural language processing and using machine learning, be able to remove the proper nouns that might be such things as job role, familial relationships, or geography. Mayo Clinic chose to do something we call hiding in plain sight. So instead of actually removing Massachusetts senator, we replace it with New York congressperson. In fact, we do this for the proper nouns throughout the unstructured data. So the clinical context is unchanged, but the identifiers, those elements one might use to re-identify the unstructured data, have been in effect changed in a way that obscure the identity of the individual. From April of 2020 through August of 2020, we did this for 10 million longitudinal patient records. We then asked Vanderbilt University to certify the de-identification we had done. An objective review concluded that we had de-identified 99.6% of the data. So we take our de-identified data in a secure encrypted container that Mayo controls and audits, and bring in partners not to look at the data, but to run algorithms on the data. And the end result is an AI factory. So this discover component is a large corpus of multimodal de-identified data that is used for discovery of new algorithms, where the only thing that leaves Mayo Clinic control is an algorithm and not the data itself. But here's a challenge. If Mayo Clinic, with its 10 million patients, has multiple algorithms developed, and maybe those algorithms are used other places in the world, how are we sure those algorithms are fair, fit for purpose, or unbiased? Because the Mayo Clinic patients may very well be, although we have many international patients, but they may not be representative of the demographics or the disease states of Singapore. It's really important that we develop a validation function that allows the local tuning of any algorithm to ensure that it performs as expected, that it does not introduce bias, and that we can trust its result. Recently, the Boston Globe published an article called Healthcare AI Has a Credibility Problem. If one has an algorithm that is inherently a black box, and it was developed on a data set that may not be representative of the patient in front of you, is that algorithm really appropriate to use? Many regulatory agencies are not regulating fairness or bias or utility. They're regulating safety. So again, very, very important that we develop a product, a series of software components that can validate the algorithms against multiple data sets, very different data sets than that were used to develop the algorithm. And then once one has a library of validated algorithms, how do you deliver them in workflow so that the provider, the patient, the payer, pharmaceutical companies, the employer, whoever is the appropriate stakeholder, is able to make interventions at the right time? Again, all privacy protected, all appropriately ethical, all with patient consent. And Mayo has worked in a variety of ways, sometimes with dashboards, sometimes with electronic health record, what we call Fire CDS hooks or smart on Fire applications to deliver these algorithms and results in workflow. And I'll tell you about a few examples in a moment. Now, importantly, every time we do this, gather, discover, validate, and deliver, anything we learn is brought back into Mayo Clinic Cloud, that container under Mayo Clinic control, so that our algorithms will increasingly have a rich data set of information, so that the algorithms of the future will be even better than the algorithms of today. Next slide. So let me take you through a few case studies. Mayo Clinic, over the last 18 months, has developed a series of 14 cardiology algorithms using millions of 12-lead, 6-lead, and 1-lead ECGs we have gathered, and give you some examples of that. With an area under the curve of 0.93, we can predict the ejection fraction, the heart pump function of a patient from their 12-lead ECG. This typically has required an echocardiogram. So a simple, inexpensive test like an EKG can help us very rapidly identify patients who have or will have a weak heart pump. We have the ability to diagnose hypertrophic cardiomyopathy, look at progression of pulmonary hypertension, even diagnose acute COVID-19 infection from 1-lead, 6-lead, and 12-lead ECGs. Mayo Clinic has created a company to bring these algorithms to the world and apply them in a variety of contexts outside just Mayo Clinic patients. In fact, even empowering competitors to Mayo Clinic to deliver safe, high-quality care using these algorithms. Mayo Clinic has about 200 million radiology images. And here's an interesting question. Do we understand what is a normal expected image and the distribution of bone, of muscle, and fat in a standard radiology image? Mayo Clinic moved 200 million DICOM objects, these radiology images, to Google Cloud. And for 3 weeks, we ran 20,000 tensor processing units against this large corpus of imaging data to develop the largest in history analysis of what is a normal body composition distribution for every area of the body across multiple patients by age and gender and body type, ethnicity, etc. We now have that capacity to use the data of images of the past to be able to detect variations in body composition. If we can discover a hidden disease early, we will have the opportunity to return a patient to wellness with less suffering and higher quality. One of the most exciting things we've worked on is the notion of delivering radiation oncology services using AI algorithms. If one takes a complex area of the body, like the head and neck, if there is a tumor in the head and neck, it can take 16 human hours to create a radiation oncology treatment plan that avoids the nerves, the arteries, the veins, the critical functions one does not want to irradiate. Mayo Clinic, using its entire history of historical data, has been able to develop an algorithm that can reduce that human time from 16 hours to 1 hour by using an algorithm to create an initial auto-contouring plan. And the reason this is very interesting is it turns out linear accelerators all have a standard API, a standard way of programming auto-contouring. It is a very reasonable assertion that linear accelerators throughout the world can be programmed remotely using AI augmenting human decision-making to scale expertise to a much greater extent than ever before, bringing high quality, safe and quality treatments to more patients than we have in the past. My wife was diagnosed with stage 3A breast cancer in December of 2011. She's completely fine today. Here's an interesting question. If we have genotype, phenotype, telemetry, and other data, can we forecast, can we predict a subset of women who will develop breast cancer and who, if taking a medication today, can avoid breast cancer entirely? And the answer is we can. And our oncology team has developed a breast cancer prediction model with 84 input variables that can identify a subset of women for which medication therapy pre-cancer avoids cancer entirely. Now, I have talked to my wife about this, and she said this notion of avoiding the radiation, chemotherapy, and surgery, of even taking a medication with side effects today to avoid cancer tomorrow, would be something that is very well aligned with her desires. Because remember, the patient always comes first, and the patient will ultimately decide what course, what journey is best for them. And I'll in a moment tell you about some of the things we've done for high acuity, serious and complex delivery of care at a distance, which has been increasingly important during this COVID-19 2 years we have all lived through. So we'll get back to that in a moment. But first, I want to talk about a few critical items we must take into consideration as we are using the data of the past to develop AI algorithms that will serve populations in the future. So next slide. I think we would all agree that we must protect patient privacy. The only way that we are going to develop trust, if we are to develop population health models, analytics, visualizations, and algorithms, we must ensure that the patients feel their data is used with their consent, that their data is used with respect for their privacy preferences. So as I've said, Mayo Clinic de-identifies the data, changes certain aspects of the data so that it is not readily re-identifiable, keeps it in an encrypted container under its control with its auditing, authorization, and access. And no data leaves the container, just knowledge. This multi-layered defense, we feel, is a way to keep that patient data safe and respect patient preferences. Recognize that, of course, certain national or international laws may restrict our uses of data. And again, we will remove patients if need be, based on the nature of international law requirements. Next slide. Another aspect of use of data is to recognize that healthcare is more than just biology. If we think about socioeconomic issues, social determinants of health issues, access issues, there are many externalities that are impactful on the care that patients experience, on the lives that patients experience. So as we consider these algorithms, it must be critical that we take into account how they are going to apply to different populations based on education, income, literacy, technological comfort. We also must recognize that there are variations across patient care cohorts based on where they live or how they are treated by their clinicians. So tailored action is necessary in the delivery of any digital intervention. And let me give you an example. Some years ago, a number of engineers from a very large tech company visited Boston and asked to be taken to a clinic where some of our most disadvantaged citizens are cared for. These engineers walked up to a homeless gentleman and said, "What is your favorite wearable?" And the gentleman responded, "Socks." I tell you this example because as we make technology interventions, we must meet the patient at their level of technological comfort, recognizing that the notion of providing digital solutions may not meet the needs or desires of every patient. We must take into account personal preferences and experiences. Next slide. As well, as I mentioned, socioeconomic status is a very important variable to consider. Recently, Mayo Clinic published a paper looking at some very well-known algorithms that have been published over the last several years and were claimed to have been validated and seem very reasonable and fit for purpose. When we looked at these algorithms with fresh eyes, we stratified a population into 4 quartiles of socioeconomic status. A particular algorithm that we published about was pediatric asthma exacerbation prediction. Could you predict when a very severe asthmatic attack would occur in a child based on history, using variables such as pollen counts and weather and steroid use, variety of other inputs? What we found is those algorithms were notoriously incorrect when you looked at the lowest quartile of socioeconomic status. They were not as predictive as you'd like. And there's a whole lot of reasons that may be true. Maybe there's more dust in the household. Maybe medications could not be afforded or filled. Maybe there are stressors. Point being is that it is really important as we develop these algorithms to start looking at some of these things and incorporate them into the tuning of those algorithms. One example, we've developed an algorithm we call houses. Based on addresses in the United States, we can actually understand what is your access to good food or clean air or medical care or education, and use even just the house address as a part of a prediction model to help understand how to tailor care equitably, ensuring you get the right amount of care to get you to wellness. Next slide. So taking into account all those notions, the phenotype, the genotype, the telemetry, the imaging, the socioeconomic status, the patient preference, can we deliver high acuity, serious and complex care to populations at a distance? Now, I'm an emergency physician, and of course, I ask myself, does the science support treating patients in a non-traditional setting? Can you take COPD, congestive heart failure, pneumonia, cellulitis, post-operative care, and deliver it successfully in the home? Mayo Clinic very often starts small, thinks big, and moves fast. So we started in 2020 to look at, could we deliver the same Mayo experience in the home? Remote patient monitoring, dashboards, care plans, AI algorithms, supply chain, staffing, all these considerations were made. We planned, we delivered care to 1 patient, then 10 patients, then 100 and 1,000 patients. Now, we've treated, as of today, almost 3,000 patients with high acuity, serious and complex illness in non-traditional settings, in their homes, in hotels. And what have we discovered? You need a new class of caregiver. You need a virtualist, a set of specialists who are accomplished at delivering high acuity care using various kinds of technological means. You need a supply chain to the home. You need connectivity to the home. But you also need the notion of, can you have a regulatory framework, a set of laws that actually support these new kinds of care models and reimbursement that pays for it? We, in our first several thousand patients, have achieved the same quality, the same safety, the same outcomes, but much higher patient satisfaction, because we're treating the patients in a familiar environment surrounded by their loved ones. We've eliminated nosocomial infections, reduced readmissions by 2/3, and even eliminated such things as sundowning. And that is, an elderly person is often confused in a hospital environment. It's an unusual environment. They're in their home. Those kind of mental status changes don't occur. Next slide. As I said, when one thinks about digital health and population health, it's critical that you think of the technology interventions, as I've just described about, in remote patient monitoring. But you also recognize that there are cultural changes, financial issues, and a regulatory landscape. COVID has been a tragedy worldwide, but it has resulted in cultural change about expectation of remote care capabilities, home diagnostic testing, more virtual care, and even high acuity care. Regulatory waivers and changes have enabled us to deliver these new care models and be paid for them in these non-traditional settings. So if the patients expect it, it's reimbursed and regulations support it. This is a perfect storm for innovation at scale, which is why we've been able to now serve multiple thousands of patients in this new model. Next slide. Just two more points, and I look forward to your questions. I said a few moments ago that AI has a credibility problem. And part of that is these new algorithms, these new analytics, these new data visualizations we're creating for populations are often a black box. I think it's critically important that if we are going to use an algorithm across a population, that it has a nutrition label. When you buy a can of soup, you know how many calories or grams of fat or sodium might be in that soup. When you get an AI algorithm, do you know how it was developed, where it's useful for purpose? Its performance characteristics that you should expect. You don't. Mayo Clinic is leading the creation of an international coalition, nonprofit, all for the benefit of society, to create a standard labeling protocol so that as algorithms are developed, full disclosure about how they were developed and their performance is made available to all. This is just an example for you of a kind of data transparency. Next slide. So in summary, when you look at these last 2 years of Mayo Clinic Platform, our work in moving 60 petabytes of de-identified data to the cloud has enabled us to create a series of AI algorithms, validate those algorithms, and introduce those algorithms into practice. We've launched a company, as I've mentioned, to help with spreading the ECG algorithms around the world. The de-identified data, keeping patient privacy first, enables us to make these new discoveries. It also enables us to bring ecosystem partners, collaborators, and joint ventures to the data to create new algorithms, and that has been quite successful with multiple international partners to date. Nearly 3,000 patients have been treated in our acute care at home, this notion of serious and complex care at a distance. And through association, joint ventures, and collaborations with multiple startup companies around this ecosystem, we've generated significant equity value for Mayo Clinic along the way. So that gives you a sense of our Cure, Connect, Transform progress to date. But very importantly, I look forward to working with you, because this, as you heard from the last speaker, will take a village. And if we're going to develop these new technologies and use them globally, we must work together. I look forward to your questions.
All right. Thank you. Thank you, John, for your invaluable insight. We'll now begin the Q&A segment for you, if that's okay. And I have a few questions for you. I mean, the audience are coming in, the questions are coming fast and furious. And one of the key, most popular questions is, what's the failure rate for innovation is pretty high. I mean, it's quite frightening in Singapore. We have a disease called pilotitis, right? Where a lot of pilots couldn't scale beyond the proof of concept phase. So how does Mayo Platform actually increases the success rate of innovation for Mayo?
Well, let me answer this in two ways. So I think we all recognize that if we take some of the great innovators of our time, say Steve Jobs or Elon Musk, any of the innovators that you may respect, they fail about 40% of the time. So I guess the question is, what's an acceptable failure rate? When I first joined Mayo Clinic 2 years ago, I asked the board, if Steve Jobs failed 40% of the time, are we allowed, in this bold approach to creating innovation, to on occasion have failures? And they said, well, the only way that one can achieve breakthrough innovation is to take risk and recognize that you will have some failures along the way and learn from them. So failure for some portion is an acceptable outcome. But to your point, there are standard operating principles at Mayo Clinic that ensure that our failure rate is lower than you would expect. We don't outsource our core functionality. We don't sell our data. We don't lose control of our customers. Mayo Clinic has 73,000 employees. It has a huge amount of experience that enables us to set guardrails. So we innovate, but we innovate within guardrails to ensure that if something is going off course, that we can make a rapid correction. So I'd summarize by saying failure to an extent is part of innovation, but bringing in a huge amount of folks who have failed in the past to provide guardrails and guidance and expertise as you innovate will minimize your failures.
John? All right. There's a very interesting question from the audience asking about how do you balance gathering data versus privacy policies? How do you balance that intricate balance here?
Right. Well. So here's I'll ask you an interesting question. So I am the second human sequenced in the Human Genome Project. My phenotype, my genotype, every aspect of my data has been public for 15 years. And I said, that's okay, because my preference was to empower science and research with data. My mother is 80 years old. If you asked my mother, would you share your genotype with the world? She would say, well, I don't think so. And of course, she did consent, by the way, that half her genotype is shared through my genotype, so she gets that. Each patient will have their own preferences. And maybe as we look at our data sets, you recognize that some have more sensitivity than others. I think we might all argue that the genotype, or such things as behavioral health or substance abuse history, these may be more sensitive. Mayo Clinic over the last year has been working on a novel consent that gives patients not infinite choice, that's very, very challenging to implement, but 5 different choices that help them qualify what data can be used for what purpose, for research and discovery. So to me, the right answer to your question is a combination of, as you heard from me, de-identify, keep it completely segregated from any re-identification or public release, but at the same time rethinking how consent can be more granular to ensure going forward that patients are truly telling you their preferences and their preferences are respected.
All right. Thank you, John. All right, I think it has really been a pleasure having you speak to us, sharing your insight and all the various insightful gems that we can learn from you in Singapore. All right, so thank you, John. And thank you everyone for participating so actively in the Q&A segment. And we will end this segment and proceed to the Let's Chat segment. Thank you very much.